Thank you to the College for the honour of presenting the Kincaid-Smith Oration. I was Priscilla's resident at the Royal Melbourne Hospital, and I think that we were all somewhat afraid of her reputation as a physician and also as a leader. In 1976, Priscilla and I headed north to Sydney to become members of the Council of the College of Physicians, she representing the Fellows and I representing that then dying group of people, the members. I apologise for this. The council was chaired by AOM Mike Gilmore, the second New Zealand president of the college, who's pictured here in front of a picture of Sir Edward Sayers, the first New Zealand president of the college. Mike Gilmore was a lovely man and very tolerant of a naive and somewhat pompous young physician from Melbourne. He did place me and Priscilla on a committee to look at the structure and function of council subcommittees under the chairmanship of Barry Firkin, which met, and I got to know Priscilla much better and appreciate her strength of character and humour, as well as her political ability to get what was called the Firkin rules through an ambivalent and somewhat antagonistic council, which it did so. But that seems a long time ago, and it must be because the Firkin Committee was the answer to a question in the history part of the college newsletter. If a topic appears in the Australian Financial Review and the New York Times in the same month, it must be of importance to the community. And this occurred in April of this year, where there were two articles on health technology, its use by physicians and the cost. 25% of the increase in cost to health has been estimated to be due to new technology and its use. The economics imperatives of doing this better and of saving money while still maintaining standards become increasingly important. Evidence-based introduction of health technology began in 1998 when the then Australian Health Minister created MSAC, the Medical Services Advisory Committee, which included New Zealand members. Decisions were to be based on safety, effectiveness and cost effectiveness. It had the ability to take items off the MBS, although it took 6 years to do so. And it only applied to items with Therapeutic Goods Agency approval. In 2002, Monash Health set up in parallel a new technology and clinical practice committee to initially look at the introduction of new technology to the organisation, but then to look at change of use of technology and to see whether that was evidence-based. And finally, and more recently, to look at disinvestment of technology, which I'll define later for you. This is a graph of the time of diffusing of technology, and that's where the hospital-based technology groups look at, just at the beginning to when it starts to diffuse, where the evidence is less and the Australian evidence is significantly lacking. Up here is where MSAC tends to look, where there is more evidence and evidence enough to make cost effectiveness. New technology or clinical practice is a therapeutic intervention or diagnostic procedure that is considered by a reasonable body of medical opinion to be significantly different from existing clinical practice In Australia, it must be TGA approved or available under special access approval. And in our case, at our organisation, it must be new to Monash Health. And even if it's done elsewhere in Melbourne or Australia, it is still looked at. Change of use refers to a new indication for use of an existing technology, for instance, laparoscopic colectomy, where laparoscopy is done but had not been done for bowel surgery, and the use of existing technology in a new patient group, for example, cardiac MRI. The composition of our group has changed over the years as we've refined it and sought advice from elsewhere. And our last change was made after a visit to Auckland to see Stephen Munn, who runs at the Auckland Hospital probably the best new technology committee in Australasia. All our program heads, who are divisional heads, are on the committee. Consumer involvement, which is important particularly for patient information sheets and consent forms. HTA-trained staff to look at the volume and the quality of the evidence. Finance to see whether we can afford it. The chair of the Therapeutics Committee, where we look at high-cost drugs. And because we look after allied health and nursing new technology as well, they have representatives. When an application for adoption of a new technology is made, there is an overview of the practice or technology and its clinical need. There is evidence provided of safety and clinical effectiveness. There is estimated financial impact. Patient information and consent form are essential, and conflict of interest is declared. It must have the support of the unit head and program director, and they must sign that they can afford it. There also needs to be consideration now of the new concept of return on investment, where we are looking more at technologies that are not add-on technologies, but replacement technologies, such as endobronchial ultrasound instead of mediastinoscopy for mediastinal lymph node diagnosis, where it is more effective, of lower morbidity and cheaper. The committee considers safety, effectiveness and cost, not cost effectiveness. Cost effectiveness is not able to be done at the place of the time of introduction of the technology that we are looking at it from the hospital point of view. And also it requires health economist input, and the cost of preparing a report like that for MSAC is about $60,000 to $80,000. We cannot afford the time nor the expense for that. Clinical feasibility, access and equity, and legal and ethical implications. In relation to safety, it is comparison to current practice and whether it is able to be considered in the same light as that. The main complications and risks are looked at, and the contraindications are noted. The effectiveness is judged by the volume and quality of the evidence, the clinical impact, and the applicability to our own patient population. The cost is the affordability, the value for money, the return on investment, and the disinvestment. And disinvestment we'll discuss later, which is where an obsolete technology is removed or replaced, either totally or partially. The clinical feasibility includes the resource implications in the impact on other services. For instance, when EBUS was introduced to our hospital, we had to find a list which displaced an endoscopic list. There is also whether we have the people in the organisation to do this appropriately. And in the case again of EBUS, we had to send somebody off to be trained because there were a limited number of people who could use it in Melbourne at the time. And then there is the training of other people and how soon we should allow people to be trained by someone who has only learned the procedure themselves. The days of see one, do one, teach one have gone forever. The change of use of an existing technology or procedure is similar with the resource implications, the impact on other areas, and training and credentialing being looked at. But each change of use of an existing technology is looked on as though it were a new technology. We also look at research projects involving new technology or clinical practice. Our organisation has decided that it is not the role of research and ethics to decide whether someone is trained well enough to do a procedure or whether there is evidence enough to go ahead with it with the safety. This is the role of the organisation from a legal and ethical point of view. There is also the problem of credentialing people to do new procedures, especially first in man. And an example of this was in renal artery denervation, which was done by cardiologists, although it was found that the cardiologists had never actually formally been accredited to cannulate the renal arteries. The impact on other hospital services for research projects is important. For instance, in cardiology with aortic valve, percutaneous aortic valves, the impact on cath lab time and space has been quite major, and the cardiology program has had to reassure us that they can do their work inside the time as well as doing the research. The monitoring of evidence-based of these new technologies are for a period of 2 years before they are considered standard practice. There is 6 monthly monitoring of audits of the new technologies, and these audits are generically improved by the Human Research Ethics Committee as quality assurance activities so that they can be published. Notification of serious adverse events, as with HREC, are reported. The reasons for what we think is success of this committee has been the support of the executive of the hospital, in that we report directly to the Executive Management Committee, and this support is necessary for any success. We have health technology assessment expertise from the Centre of Clinical Effectiveness, where we have a group of people who are trained through the Cochrane collaboration to look at the evidence. We have streamlined and user-friendly processes, at least we think they're user-friendly. And they seem to be fair, and the committee is seen to be supportive by the medical staff, despite us rejecting projects from time to time. There are also insurance implications in that if a doctor does not get approval from this committee, there is doubt as to whether the hospital insurers would cover him or her in the case of an adverse outcome. And we need good relations with procurement, theatre and HREC to know what things are being introduced to the hospital that may not have gone through our committee. And also between procurement and us, there is cross-referencing of projects. Finally, the important topic of credentialing, and this is done by the committee and is probably one of the most important things that we do to make sure that people are appropriately trained to do and use the new technologies and new procedures that they wish to introduce. To disinvestment, and as I went to a talk which said disinvestment is not a dirty word. Disinvestment is a controversial word and was the subject of the use of the word was subject of a conference in America 2 years ago where a number of other alternatives were put up. Disinvestment relates to the processes of identifying and withdrawing partially or completely health resources from obsolete, unsafe or evidence-lacking procedures, technologies, practices and pharmaceuticals that deliver no or low health gain. It is thus the freeing up of resources for more effective, safe, cost-effective and prioritised health services. The alternative names that have been put forward and rejected are reprioritisation, reappraisal, optimisation, substitution or reinvestment, de-implementation and health technology reassessment. It was felt that disinvestment was too embedded in the world literature to change at this stage. So why is disinvestment important? There's the ethical imperative to ensure patient safety and thus avoid tests and procedures that may cause harm without commensurate benefit. There is the quality imperative to reward and measure best practice. And there is the economic imperative to reduce spending on technologies and procedures that lack evidence. The scope of the problem is wide. Prasad et al. Reviewed the New England Journal from 2001 to 2010 for medical practice articles. They found 1,344 articles, 981 looked at new practices, and 363 looked at established practices. Of those 363, 146 reversed that practice, but you would be surprised about how few hospitals have implemented those reversals. Identification is just the start, implementation is the hard part. The history of disinvestment goes back a long way. In 1976, the Blue Cross Medical Necessity Project 76 looked at outmoded and useless procedures. In 1978, the National Centre for Healthcare and Technology was founded, but was disbanded in 1982 because those two liberal groups, the American Medical Association and the Republicans, opposed it. In the 1990s, Canada had 46 procedures removed from its schedule, and in Victoria, the public hospitals ceased non-medical circumcision, vasectomy, gender realignment, cosmetic surgery, and IVF. In 1999, France removed 200 or more items from its medical inventory. It probably looks a little better than it was, as they had homeopathic medications on their inventory at the time. In 2004 came a landmark decision in Australia that in the RACP determination by MSAC, the Gastroenterology Society of Australia finally agreed that diagnostic ERCP would be removed from the schedule except for those patients in whom an MRCP was contraindicated, allowing for a saving of money to introduce a better and safer service. In 2005, the National Institute of Health and Clinical Excellence coined the term disinvestment. In 2012, the American Board of Internal Medicine developed their Choosing Wisely lists, which I'll discuss later. And in December 2012, Adam Elshaw published in the MJAA 150 low-value procedures in Australia. There are many potential routes of identification. MSAC and the Federal Australian Department of Health are reviewing item numbers and have currently 22 item numbers on the schedule being reviewed to see whether they should not be removed. There is return on investment, which I'll discuss in a moment. There are the low-value lists, including the nice do not do list. There is in our hospital is the Evidence Dissemination Service and Journal Watch. There is individual clinician identification, and finally there are external sources and personal communications. Return on investment in our state has included EBUS, FibroScan, green light laser, sleeve gastrectomy, and pharmacy. EBUS was introduced into Victoria 5 years ago and was a case of substitutional reinvestment as it replaced mediastinoscopy. There was significant saving of $5,000 per case cheaper. It was self-funding after 2 years, as long as our respiratory endoscopists don't keep breaking the machine. And it had a decreased morbidity while still retaining a diagnostic capability equal to mediastinoscopy. FibroScan was introduced 4 years ago and replacing liver biopsy for fibrosis in the follow-up of hepatitis B and C. A FibroScan machine costs $80,000. It saved 90 biopsies at approximately $1,000 each per year. When initially introduced, it could tell you that you had 0 grade 1 or grade 4 fibrosis. It can now differentiate 2 and 3. The improved technology has improved its utilisation and will make it more cost effective. Green light laser for benign prostatic hypertrophy has been used to show savings by decreased bed days. There are a number of ways to look at savings in disinvestment. It also allows you to use it for patients with bleeding disorders and other patient groups that couldn't be used before. Obesity surgery, which is probably better termed metabolic surgery, as with the numbers of patients presenting for obesity surgery, it's the ones with metabolic components such as sleep apnea, with pulmonary hypertension, with unstable diabetes are the ones that are going to be operated on. And we introduced sleeve gastrectomy to replace lap band, which has been ceased, with in-hospital savings, Medicare savings, more effective weight loss, and a better tolerance by the patients. One could argue that Roux-en-Y or diversion surgery is probably better, but it does have a higher morbidity and cost. In our pharmacy, we have taken to using only one product of a group of drugs. For instance, we only use atorvastatin and perindopril. These are evidence-based, as you would know from the literature in relation to following up myocardial infarction, diabetes, and other conditions. If a patient comes into hospital on another statin, they are continued. These drugs are reviewed 5 yearly, and as I said, there is no change if the patient is already on other drugs. The saving over 5 years has been $3 million, which has been reinvested back into the pharmacy budget. And we are continuing to singularise drug groups up until now. It's interesting to consider what the impact of generic drugs will do. In New Zealand, it has saved, some have estimated, up to $1 billion, and the savings in Australia, if PBAC went to generic drugs, would be enormous. But I don't think that's a job for Monash Health. Low-value lists have been, apart from the Prasad list, there have been 3 major lists quoted in the literature and used. And I apologise for this, but this just lists the American Board of Internal Medicine's initial list of 26 special societies and colleges in America who put together 5 do-not-dos in their area of specialty, things that they felt that the practicing physician, general practitioner or other practitioners should not do. This is from our sister college, the American College of Physicians, and you can read this for yourself, but the one that made it into the financial review was do not obtain imaging studies with patients with non-specific low back pain. The cost of low back pain imaging in Australia of a non-discriminatory nature is estimated to be in the hundreds of millions of dollars. The other was, of course, the routine use of tests pre-operatively. There were problems with the Choosing Wisely list, which has now been expanded to greater than 30 organisations, that societies tended to name other specialties as low-value items. 29% had targeted radiology, 21% targeted cardiology, not nearly enough, and 21% targeted medications. Most proceduralists included few operations from their own area. ENT, for instance, despite the long history of the problem with grommets, elective adenoidectomy and tonsillectomy, managed to name 3 diagnostic imaging procedures and 2 antibiotic regimes as not to be used. While these are important, a greater insight by these societies would be appreciated. Although the gastroenterologists, of which I am one, did name 2 money-making procedures that they recommended should not be done. The first being if you had 1 or 2 small polyps that were non-dysplastic, that you only needed a follow-up colonoscopy in 5 years. And the second being for Barrett's esophagus, where if you have non-dysplastic epithelium on multiple biopsies 2 years apart, then you don't need a scope for 3 years. Although interestingly, and this is the problem with this area, there's been a recent guideline that suggests if you have that 2 biopsies that are clear, you probably don't need a gastroscopy again. The cognitive specialists, of which we are, named very few of their revenue-generating procedures, except for the general physician group, who queried whether annual checkups had any evidence base at all. And this is perhaps something that we need to think of with government while we face up to the $7 additional co-payment. The American board stated that this is a quality but not a cost-containing exercise. But one would have to be naive or cynical to believe that the American insurers, as predatory as they are, would not latch onto this as a guide to insurance and how things will be paid for in the future. In December 2012, Adam Elshaw published 156 low-value healthcare practices in the MJA. He trawled through over 5,000 articles which had recently been published on technology and practice and were on the Australian schedule to come up with his 156. And I'll only deal with one at the moment because it is an intriguing study of what to do. In 2010, the Cochrane collaboration produced a report on IVC filters. For those of you who use IVC filters, you'd be glad to know there has been no prospective randomised trial on IVC filters in the world literature ever. It is a problem in that the 2 areas that are used mainly, that is patients who have a bleeding disorder or patients who'd had recurrent embolism on top of anticoagulation, there is actually no evidence of it at all. At least there wasn't until the Muriel in the Journal of American Cardiology in April of 2014. Sort of just squeaked in before this oration. This recent study looked at their international register of 40,000 patients with pulmonary embolism and took the 340 patients who had had IVC filters put in because of bleeding risk and compared them to age-matched, diagnosis-matched, sex-matched on patients from the register without filters for the same indication. There was a non-significant trend to decrease all-cause mortality with a p-value of 0.12. You find in this literature that there's a trend towards most things. There were certainly decreased deaths from PE with a p-value of 0.03, but the trade-off was that the recurrent VTE rates in the IVC filters was increased by 10 times. The outcome for us at Monash Health was that we were less than courageous and kept IVC filters on our schedule, but limited to the use of a referral to the head of haematology. The NICE do not do recommendations, and there are now over 800 of these, are gained during the process of guidance development, i.e. guideline development, of NICE's independent advisory bodies, and they often identify clinical practices that they recommend should be discontinued completely or should not be used routinely. This may be due to lack of evidence that the practice is not on balance, evidence that the practice is not on balance beneficial, or lack of evidence to support its continued use. It is these recommendations that have been pulled together into the Do Not Do database, and this is a page from it. And the interesting one is do not use CT of the brain to exclude raised intracranial pressure, which is frequently used at our organisation. The Evidence Dissemination Service is something that we run at our organisation, where we take a review of all systematic reviews and to see whether they apply to our organisation and to see whether our organisation complies with these reviews. It has been satisfactory from a quality but not a disinvestment view, as in out of the 53 systematic reviews, we've only had 3 cases where where the wrong practice is still being continued at the organisation, but 3 out of 53 is probably better than none at all. And Journal Watch we have been doing since about 2009, and interestingly doing the same sort of work that Prasad was doing. These are just 4 examples of where evidence has been gained from the journals to allow us to consider disinvestment of procedures. In 2009, 2 trials appeared back-to-back in the New England Journal of Medicine. The first was by Rochelle Bookbinder and her group from Cabrini Hospital in Melbourne. The second was a Harvard study that interestingly had most of its cases out of St George Hospital in Sydney. Both of them were sham-controlled trials, and both of them showed no evidence that vertebroplasty decreased pain or return to mobilisation. And we ceased vertebroplasty at Monash Health. Of interest to me personally is that I put 3 patients into the Bookbinder trial and they all got better. But we have gone with the evidence. In January of this year, the Coral trial came out. This was renal artery stenting for atherosclerotic disease and hypertension. There have been 3 trials just to show that 2 trials weren't enough to tell us that it didn't work. It showed no benefit again, and the procedure has been withdrawn from use. Patent foramen ovale closure for cryptogenic stroke is an interesting study. There have been patent foramen ovale has been found in 50% of these patients, as against 25% of the normal community. There have been 3 trials and none reached their primary endpoint of showing that stroke was prevented. The major trial trended again to decrease stroke and TIA with a p-value of 0.08. However, there was an increase in atrial fibrillation of 2 to 3 times, a trend to increase pulmonary embolism and right atrial thrombus, and the subgroup analysis were only really positive in atrial septal aneurysm and a greater than 2 to 1 right to left shunt. We've had a continuing standoff with our colleagues in cardiology. Their last 10 PFOs, 5 of them were closed for this doubtful indication, and I'm not actually sure how we're going to get them to stop. Renal artery denervation, I couldn't resist putting this up. For those of you that have read the literature recently on renal artery denervation, it came in with an enormous clatter, and there were even talks of a Nobel Prize going to the Alfred Hospital. The Medtronic's trial of Simplicity 3 catheter came out in the New England Journal in April 2014, but it had been floated as early as January that the results were not as they should be. This was the first sham trial. It was the largest trial of 408 in each arm, and it failed to reach its primary endpoint. Medtronic took the extraordinary step of closing down its trials in India, Japan and America, and getting out of the renal artery denervation area. The intellectual property for the renal artery denervation had been bought for $800 million. The question then became, should the procedure continue, and what was the state of trials? We stopped the procedure on any other patients apart from trials patients and debated extensively whether, as an editorial in the British Medical Journal said, that it was unethical to continue trials when you knew something didn't work. However, although the Royal Melbourne and the Alfred stopped their trials, we agreed, as it was a different catheter, to allow our trial to continue. I'm still not sure we were right. Clinician identification will continue to be important in improving care and getting rid of or changing the guidelines for procedures. Micturating cystourethrogram used to be used for virtually every child who had unexplained urinary tract infection. It was changed following guidelines by the Director of Paediatric CT so that it could only be ordered by a paediatric urologist or nephrologist. The reduction has been from 200 a year to 30 a year, showing appropriate care. The saving has been $50,000 a year in procedures. The Auckland Hospital group published on acoustic neuroma follow-up and showed that if there's no growth, MRI is only necessary for 4 years following the initial diagnosis. There are major challenges to disinvestment. There's no agreed disinvestment methodology. There's a lack of clinical administrative will to evaluate or establish practice. There are vested interests from manufacturers and some clinicians. There are clinical advocates who are reluctant to change, as this is their whole raison d'etre in life. There are difficulties often in identifying low-value services, although there are greater numbers of those being published. There is a lack of communication at a national level between regulatory agencies. There are different things, for instance, that can be done in Veterans Affairs than can be done on the ordinary health. There are different standards of evidence needed to start versus to cease practice, and it's been compared to criminal versus civil levels of evidence, that to get something in you only need a balance of probabilities. To get something out you need it to be beyond reasonable doubt. There is practice sensitivities that it's hard to disinvest in cancer and paediatrics because there are tremendous social pressures. And up until now, there's been a marked lack of resources put into this area. The conclusion from Volp et al. In the JAMA in 2012 that the next step is to move beyond a list of low-value services towards testing of approaches to reduce their use that are informed by clinical evidence. Given fiscal realities, reducing low-value services is what will allow continued support for high-value services. So where for Monash Health? We feel that we need to get into big ticket items, so we're going to take on women, the infection control group, and the orthopaedic surgeons all at once. Screening mammography was the subject of a perspective article in the New England Journal in April from the Swiss Medical Board, who had reviewed all the evidence and showed that screening mammography hadn't been looked at since 1991, that the change in management of breast cancer had improved the results so that the marginal benefit that was gained then was probably not present now, and that the Canadians, in 44,000 people, showed 480 positive, of which 106 were false positives with the risks of that. It needs to be reviewed. Glove and gowning for decreasing the spread of VRE and MRSA is present in many hospitals. The evidence is a quasi-experimental before and after study, and admittedly published in the New England Journal of Medicine in 2011, which is the only data for which this is based. There have been two trials, one in JAMA and one in the New England Journal of Medicine in 2012 and 2013, which shows that it doesn't work. We are continuing to use it in many hospitals at great cost, not only to the hospitals, but to the patients, as everyone knows that when someone is in isolation and you have to gown and glove to go in and see them, they get seen less. And there's been one fascinating study that shows that the notes in the history are less. Finally, knee arthroscopy. For some time we've known that, according to the literature, arthroscopic washout of the knee for osteoarthritis doesn't work. I had 2 of them and they both worked. But I think that I'm the perfect person to go into the control arm, that I get everything that gets better. However, the second study in December of last year in the New England Journal showed that for patients without osteoarthritis who have meniscal problems, that arthroscopy is no better than a sham operation. There also needs to be more focus from the organisations that we work in on disinvestment and money spent to save money. So what about the RACP? It should be active in this area. Professor Ian Scott and I were present at a workshop on disinvestment or low value items at the Grattan Institute, which is a health think tank based in Melbourne. And they were decrying the lack of interest of the Royal Colleges in this area. I think it is something that we should be into, as we don't have the conflict of interest of the special societies, and that we are a patient-centred rather than a doctor-centred organisation. As Shakespeare said, some are born great, some become great, and some have greatness thrust upon us. I hope that, like in revalidation, the college becomes great rather than has greatness thrust upon it. Finally, I would like to quote from that eminent journal, the New York Times, from Dr. Lowell E. Schipper, the chairman of a task force on value in cancer care at the American Society of Clinical Oncology. We must understand that we as doctors should be and are stewards of the larger society as well as that of the patient who is currently in our consulting room. Thank you very much.